doing this because it worked to now putting a patient on non-invasive ventilation with a mask, same concept. There's the IPAP, and then the EPAP is part of it, and we'd be giving them 100% oxygen. All right, so this is this is just a different ventilator screen. So it doesn't matter which ventilator you see at your hospital. It's the exact same thing like I told you. You set parameters in one location, you find out what the patient is doing in another one, and then you also have a list of alarms that let you know what is the problem. The ventilators, by and far, if the studies have shown that ventilators will not fail, it's always a user error. I think the percentage is like less than 2% of some issue being related to a mechanical issue with the ventilator. So here's some of the terminology that you might have heard: mandatory or controlled. Okay, the ventilator controls everything. Assisted means that the patient only triggers the breath, but the ventilator controls everything thereafter, right? And then spontaneous. The patient is the one that's in full control. So remember that one mode that I told you, remember AC, assist control, right? If the patient wants to trigger, he gets a breath. If he doesn't want to trigger because he's too sick and he's just apneic or sedated or paralyzed, then he gets controlled. And then the patient that's about to be extubated, he's spontaneous. He's breathing on his own. And you would see that on all these ventilators, they let you know, is it assist, or is it controlled, or in this case, synchronized? Or I'm sorry, not synchronized, spontaneous, sorry. So those are your three top modes there. This is just showing you assist control, okay? So just telling you that the rate is only as a backup, right? So I dialed in a rate of 10, but if the patient wants to get 20, he gets 20. Okay, so it's only as a backup. If he stops breathing, he's getting his backup of 10. And so notice here, I have, let's say a backup rate of 10. So if the patient wants to take a breath, they could. And I would see it on my graphs, I could see that there's a dip. The patient makes a negative effort and the patient gets a breath. Okay, if the patient does not take a breath, then it becomes a controlled breath. There is no dip in the pressure. It's just the ventilator's ready to deliver. If the patient takes no efforts, then every breath is a controlled. There's no dip in pressure there. And so that would let me know it's a patient-triggered breath. That's when you know if the patient's really sick or not. If the ventilator is controlling them, or if they're assisting the ventilator, or if they're just doing spontaneous. So all the settings here are the same. Show you a couple of short videos. I don't know why it's not working right now. I think it's just slow. I think it will start. Hold on.
So that's a volume control mode for a patient that would be apneic. Pressure and flow, we do not see any patient efforts being taken. And in the event that the patient starts waking up, you will begin to see some triggering. In this case, the ventilator is set on pressure triggering. And right there, you can see the pressure trigger effort. And another one prior to the machine breath. The machine will respond to every patient breath. And in this case, the patient stopped breathing, fell back to sleep. And if the patient starts breathing and is anxious and takes a lot of breaths in a row, the rate will increase.
Then you have that second one, the one where the patient's getting better. Patient's getting better, you don't have to fully control them. Patient breathes spontaneous breaths in between some mandatory breaths, right? That's the intermittent part. And the mandatory breaths are delivered just like you would anybody else, a tidal volume, flow rate, PEEP, and FiO2. And if the patient wants to breathe on their own, the ventilator does not ignore that. It allows them to have their own spontaneous breaths, and we assist them with some extra pressure support. Okay, so pressure support is the difference between IPAP and EPAP. Okay, so if I want a pressure support of 5, then that's just a little bit of assistance. Or pressure support of 10, a lot more assistance. There's a picture of SIMV. Here's the mandatory breaths, the big ones obviously, but in between the big ones, the person can breathe spontaneously, and I'm helping them out with some pressure support. So the settings are, everything's the same, except now I've added pressure support to those spontaneous breaths. So you know that that's the case because if you were to look at the volume, the mandatory breaths are delivering a bigger amount of volume versus the smaller amount of volume for somebody to breathe on their own. But they're getting better. And I'm just using some control and allowing the patient to do some of their own breathing. Then the last one is spontaneous, just letting the patient control everything. So they determine how big of a breath they take or how shallow of a breath or even how fast. The only thing I do is I support their breathing, their spontaneous breaths with pressure support. So notice this is this tidal volume that they're giving, or the breath that they're getting, it's whatever they determine. If the patient starts breathing more shallow, then the next one will be, you'll see them that they're dropping as well.
Pressure support ventilation is a spontaneous type of ventilation. The patient initiates every breath and the ventilator supports them so that the patient controls his own respiratory rate. The support is provided as pressure delivered by the ventilator in addition to the PEEP. Pressure support ventilation can be delivered not only with the endotracheal tube but also through specialized face masks. During pressure support, the inspiratory pressure level is kept constant and there is a decelerating flow waveform. The trigger to start each breath is more frequently a variation of flow in the airways. The change from inspiration to expiration, called cycling, begins when the flow reaches a set percentage of the peak flow. The reduction of the flow cycling setting increases the inspiratory time. The tidal volume is not fixed and it can change breath by breath, mostly on the basis of the pressure support, the inspiratory effort, and the compliance of the respiratory system. In conclusion, the settings we can use to regulate the PSV are PEEP and pressure support above PEEP, flow triggering versus pressure triggering, cycling off criteria, and eventually backup setups in case of apnea.
Okay, so the other names that you heard them mention, the cycling, that's just terminology I don't think you need to know. It's more the fine-tuning when we look at the graphs and then we make adjustments there. So this is a person that is on spontaneous, or he's getting a spontaneous breath. We put alarms on all of our ventilators, just like you might have some IV that goes off and it alarms and it lets you know what's the problem, whether it be an occlusion of some type. Same thing with us. If an alarm is hit on whatever we've set, then it would tell us what that alarm is. We just need to know what is that obstruction, for example. we get that inside look, patient's lungs, just like you would get an inside look of what is taking place with the patient's blood pressure. If they have blood pressure issues, high blood pressure, some of the causes or some of the results of high blood pressure. That's what you would think of. Well, for us, when we listen, when we auscultate, this is where we can, find out, is the patient having difficulty breathing because they have a pneumothorax, the heart has failed, there's a lung infection, a pulmonary emboli, possible foreign aspiration, or maybe some constriction. Okay, those are all different things we're thinking about as we're auscultating. So if there is any wheezing, we know that the airways are being squeezed, they're being constricted, or there might be secretions in the airway and that's causing the wheezing. So that's how we assess our lungs. Here we could also assess whether this tube placement is correct or not. So there's a lot more possible problems that could occur if we intubate a patient versus trying non-invasive first. For example, in this case, just by looking at this tube, you know that this tube is too deep. So a person's going to hear the lung sounds over here on the right side, right main stem, but when they go auscultate to the left, they won't hear anything. So that's just based on how deep this tube got placed. The opposite is here with this tube. This gentleman grabbed his tube and pulled it out, and so now you're not going to auscultate nothing because everything's leaking out. Right? And this is important for nursing to know, is just the ET tube, they have a cuff. We measure the cuff pressure. This is the pressure that's lining the tracheal walls, and if we put too much pressure in here, it's going to impede that circulation, and then the patient's just going to have a necrotic airway and all the complications that come because of that. Or like on this picture where the patient pulled the tube and self-extubated, then that tube is ripping through the vocal cords that are here, and that can cause vocal cord paralysis and some other damage, some other lesions along the trachea. So this way we ask you nurses, please restrain them. And I know nursing always hesitates on restraining, but then they hesitate on sedating because the blood pressure is too low. So that's a complicated battle. But which is worse, trying to manage the blood pressure or ET tube coming through the vocal cords, right? All right, this is another complication that can happen because we have so much tubing going through, and this is where is it? I have another picture. But there's a lot of tubes going into the patient, and some of those tubes get pinched off. So our tube would, obviously, this is pretty bad, to get pinched off under a rail like that, but very common. It'll get pinched off with the bed rail, not the wheel, right? So the alarms go off, you guys, and just notice the difference. Notice the number one reason that deaths occurred in this study, the majority of the time is because the caregiver said that the alarm didn't sound. The minority of the time was that the ventilator malfunctioned. Okay, so it's always user error, and if we're not in the room, nursing's in the room, this is just almost like a dual responsibility, right? The alarm goes off. If you're able to see what the problem is, you solve it. If not, then call the RT, and the RT should be able to find out what the problem is. Okay. And very importantly, also, these alarms, once we set them and how we respond to them is all captured data. So here on the side of all the ventilators now, they have a USB port where anybody can go in and download information. So if a person is just silencing the alarm, right, or ignoring the alarm, and a death occurs during a certain time frame, it is quite simple for an attorney to come and get that information down of when that family member died and what was done about it when the alarms were going on. Do you guys rotate to King Drew? Okay, King Drew was one of the issues when they first closed down years ago. Part of the issue was not responding to alarms, and there was some deaths, and the information, like I said, it's very easy to gather. So, can't ignore alarms, right? Mm-hmm. Patients coughing, they're suffocating because they're drowning in their own secretions.